today's explainer. Let's boot up the digital board, because today we are going to master a literally super high-yield topic for your exams and prep. We're talking about gastrinoma. To build a rock-solid conceptual foundation, you really need to understand exactly how this tumor behaves, right from the basic pathophysiology all the way to the surgical table. So grab your notebooks, give me your 100% attention, and let's dive right in.
Okay, here is our roadmap for the session. We'll be going through 1. Basics in anatomy, 2. Sporadics versus M1, 3. Pathophysiology, 4. Clinical features, 5. Diagnosis, and finally 6. Management. It's a very logical, step-by-step flow, so you can easily visualize the entire concept sitting right there in the exam hall.
Section 1. Basics in anatomy, defining the tumor. Let's start with the absolute fundamentals.
Before we jump into complex cascades, what exactly is a gastrinoma? Mark this down clearly in your notes, guys. It is a specific type of neuroendocrine tumor. Its main defining job, it aggressively secretes gastrin, and this massive, uncontrolled gastrin production leads to the whole clinical picture we call Zollinger Ellison Syndrome. So remember, the tumor itself is the gastrinoma, but the resulting manifestation, that's ZES. Please don't confuse the two. It's a direct MCQ.
Now, since it's a neuroendocrine tumor, obviously it will stain positive for classic neuroendocrine markers, right? Specifically, chromogranin and NSA. But please listen to me very carefully here, and do not fall for this classic MCQ trap on the board. Examiners absolutely love testing this. See, the overall most common functional pancreatic neuroendocrine tumor is insulinoma. However, if they say the patient has MEN1 syndrome, then gastrinoma becomes the most common enteropancreatic NET. And crucially, it is the most common cause of death in these MEN1 patients. You need to keep this distinction crystal clear in your mind.
Take a look at the anatomical boundaries mapped out here. This is the famous gastrinoma triangle, also known as Pissarro's triangle. This is the classic hideout for these tumors. Just trace the points with me. Superiorly, you have the junction of the cystic duct and the CBD. Inferiorly, the junction of the second and third parts of the duodenum, D2 and D3. And medially, the junction of the neck and body of the pancreas. Memorize these exact coordinates, okay? Because our surgeons rely on them entirely.
Moving on to Section 2. Sporadic versus MEN1. The crucial differences. Now that we know where it hides, who actually gets this tumor?
Examiners love comparing these two presentations, so take a mental screenshot of this table. It's incredibly high yield. See, sporadic gastrinomas make up the vast majority, 80% of cases. Usually these are patients around 30 to 50 years old, mostly females. Conceptually, remember that sporadic tumors are single, they're large, and they carry a massive 60% risk of malignancy, usually spreading to the liver directly from Pissarro's triangle. Because they are so aggressive, the prognosis is bad, and surgery is our primary weapon. Now, on the flip side, look at the MN1-associated variants. They make up the remaining 20% and behave completely differently. Because MN1 is autosomal dominant, these patients present very early, usually before the age of 20. The tumors here are multiple, they are small, mostly benign, and they really prefer hiding out in the duodenum. So for these, we usually manage them medically with high-dose PPIs, and we only touch them surgically if a tumor grows larger than 2.5 centimeters.
All right, Section 3. Pathophysiology, the domino effect. Why do these patients come to the OPD in such misery?
Let's trace the cascade step by step. It's a very simple, logical flow. Step 1. The tumor continuously pumps out massive amounts of gastrin. Step 2. This gastrin travels through the blood and heavily stimulates the parietal cells in the stomach. Step 3. Those overstimulated parietal cells go into overdrive and release an absolute flood of hydrochloric acid. We are talking about an extreme state of hyperacidity.
So what happens when you have this massive flood of acid? Well, it has a brutal dual effect. First, the sheer volume of acid literally burns holes right through the GI mucosa lining. This gives the patient severe gastric and duodenal ulcers. Second, and this is a brilliant physiological concept, so pay attention, the extremely low pH environment created in the duodenum completely inactivates your pancreatic enzymes. Without those functioning pancreatic enzymes, the body just cannot digest fats properly. And that leads straight into severe diarrhea, steatorrhea, and generalized malabsorption.
Which brings us to Section 4. Clinical features, spotting the patient. Based on all that pathophysiology, when the patient walks into your clinic or the casualty ward, what red flags are you actually looking for? Well, the predominant symptom the patient will complain of is severe abdominal pain. And logically, the most common clinical manifestation is peptic ulcer disease. But, common things are common. A lot of people have ulcers. How do you spot the gastrinoma? You have to look for the red flags. You must suspect it if the ulcers appear in unusual distal locations like D2 and beyond.
Suspect it if the patient has recurrent ulcers with concurrent diarrhea, and definitely, absolutely suspect it if the ulcers are completely refractory to medical therapy. What does that mean? It means absolutely no healing after 12 weeks of standard treatment for a gastric ulcer or 8 weeks for a duodenal ulcer.
Now, pay special attention to the diarrhea part because it has two very distinct pathophysiological components. This is a massive favorite for examiners. First, it has a secretory component. Why? Because all that excess gastrin circulating acts directly on the enterocytes in the gut, forcing them to absorb less and actually pulling water directly into the lumen. Second, as we just discussed, it has an osmotic component. The unabsorbed fats, left over because the acid destroyed the pancreatic enzymes, remain sitting in the gut lumen and they osmotically pull water right in with them. So what you get is a brutal double hit of both secretory and osmotic diarrhea.
Okay, Section 5. Diagnosing the tumor, investigations. We have our strong clinical suspicion now, so how do we prove it?
You always start your screening with fasting gastrin levels. Let's keep the numbers simple here. If it's under 200 picograms per milliliter, it's normal. If it is massively elevated, say over 1,000, that is practically diagnostic for gastrinoma. But what if the level falls into that intermediate gray zone, right between 200 and 1,000? Well, that means we can't be 100% certain yet, and we absolutely need to perform a confirmatory test. Also, just note this down. A ratio of basal acid output to maximal acid output of greater than 0.6 is a very strong classic indicator of a gastrinoma.
So for that tricky gray zone, we move to the gold standard confirmatory test, the Secretin stimulation test. The underlying principle here is just beautiful physiology. In a normal, healthy person, administering Secretin will physiologically inhibit gastrin secretion. But remember, a gastrinoma tumor is abnormal rogue tissue. It behaves entirely backwards. When you give IV Secretin and measure serum gastrin at regular intervals, a gastrinoma will paradoxically secrete even more gastrin. If you see a paradoxical spike in those gastrin levels by more than 200 picograms per milliliter, boom, you have confirmed your gastrinoma.
All right, once it's confirmed biochemically, we have to localize the tumor before we can send the patient to surgery. The investigation of choice here is somatostatin receptor scintigraphy, commonly known as the octreotide scan. See, these tumors are densely packed with somatostatin receptors, so when we administer radio-labeled octreotide, the tumor just gobbles it up and literally illuminates on the scan, pinpointing its exact location for us.
But guys, as a good clinician, you must know the limitations of your tools. While the octreotide scan is the most specific test overall, remember our table from earlier? MEN1 tumors are very, very small. The octreotide scan simply will not pick up those tiny duodenal MEN1 nodules. For those specific patients, you must switch your modality to an endoscopic ultrasound. That's the preferred investigation there. Oh, and just a quick extra MCQ point for your notebooks while we're talking about scans. If the examiner asks you about localizing a pheochromocytoma, the investigation of choice for that is a gallium dotatate PET scan. Definitely write that down.
Finally, Section 6, Medical and Surgical Management. We know what it is, why it happens, and exactly where it's hiding. Let's fix the problem.
Let's talk strategy. Medical management primarily relies on shutting down that massive acid factory using high-dose proton pump inhibitors. We are talking 60 to 80 milligrams. For your MN1 patients, because their tumors are small and mostly benign, this high-dose PPI is usually enough to manage them, and we only operate if a lesion grows beyond 2.5 centimeters. But notice the difference for the aggressive sporadic types. We give them high-dose PPIs, we add octreotide to inhibit the tumor, and then we strictly follow up with surgical excision. And a very important historical note for you, total gastrectomy is not required anymore, all thanks to these excellent medical therapies. Oh, and if that sporadic tumor has unfortunately already spread, remember that the liver is the most common site of metastasis.
Now, when we do decide to proceed with surgery, looking at this gross specimen, the surgical approach we choose depends entirely on the precise anatomical location of the tumor that we localized on our prior scans.
The surgical rules are actually pretty straightforward. If the tumor is sitting right in the head of the pancreas, we perform a simple enucleation to carefully shell it out. If it is located further down in the body or the tail of the pancreas, we have to perform a distal pancreatectomy. And if we find it hiding out in the duodenum, which, remember, is very common especially in our MEN1 patients, the standard procedure is a full-thickness local excision of the duodenal wall.
So let's bring it all together. If a patient walks in with recurrent, unusual ulcers and diarrhea, are you confident enough now to map their pathway from a simple fasting gastrin screen straight through to the correct surgical excision? More importantly, think about this. How many patients sitting in GI clinics right this very second, complaining of stubborn acid reflux, are actually harboring one of these tumors completely undiagnosed? Keep your index of suspicion high, trust your physiological concepts,